I'm Rob Fuller. I'm an emergency doctor and I'm a volunteer with the International Medical Corps. And I'm going to talk to you a little bit about some of the lessons that I've learned from my early deployments with the International Medical Corps to disaster settings. So I want to tell you a little bit about emergency doctors if you don't know us. We're good at really three things. We're good at preparing and planning because we like to anticipate that something's going to happen, a baby's going to be delivered, we should have stuff for that, whatever. We're good at acting on our feet really quick, responding to the situation that's presented to us. And the last thing, we're good at faking it when we're lost. Because we're lost pretty often, we're pretty good at faking it. So that's kind of us. And these early deployments are interesting because the early deployments are deployments that happen before there's a habit, before there's a system in place, before there's a pattern of behavior, before there are expectations. So it's really the Wild West moments when we're kind of laying down the patterns that'll be happening. I had been talking with some colleagues. They have these centers for disaster response. It's a fantastic group here that are learning about disaster mitigation as part of their training. And some of my colleagues have disaster departments in their emergency medicine department. Give me a slide. I have, this is the University of Connecticut Center for Disaster Medicine. That's me with a blow dart gun in the tropics down in Ecuador. And that is the entire department. But you know, one guy can do a lot. You can tell the chief I've got the feathered hat on there. So, you know, everyone has their ideas about what the lessons are learned and what you can take away from those lessons. How to do it better next time, or even theoretical, if you haven't been out on a disaster, how you might apply some theory you learned in school or ideas to those. And I have my opinion too about those things. So my opinion starts with this next slide, which is a list of places I've worked at, and I call it stubbing my toes because that's how you get experience. You know, you make a few mistakes along the way. And I've made plenty of mistakes along the way, and these are the places where I've learned and made mistakes. The St. Jude Hospital in St. Lucia is a tropical hospital. I've been going there for 20 years now, and I've spent 2 years of my practicing life working there. I took a year off after my residency training and spent a year working there, and then I've gone down for about a month a year for every year, taking students and residents with me, and I've learned a great deal down there. The September 11th attacks, leading up to those attacks, me and a team of paramedics were training about how to do tactical medicine, confined space medicine, steep angle medicine, kind of weird medicine with, you know, climbing gear and that kind of stuff. It was really fun. And then in practicing for that stuff, we kind of were prepped for the September 11th morning. And my team and I went to Ground Zero September 11th. Give me another slide or two, why don't you? So this is actually the remains of that hospital in St. Lucia. It burned down a couple years ago. And they're working on rebuilding it, but that's it's a sad picture for me. And another picture is my team of paramedics and myself on September 12th in the afternoon when we were leaving after spending 24 hours at Ground Zero. And then another example of places I've been to learn some is in Banda Aceh, Indonesia. That's after their large tsunami. I was working with the International Medical Corps at that time, and we went as the first first wave of doctors to give assistance there. And this is the first day that their emergency department started to do care. I was there to help sweep out the first rubble and start taking care of patients in their emergency department. And I worked there for a month leading the emergency department section of that hospital. She sees it, she knows it, she's reading the cues. I spent a year sabbatical working in Guayaquil, Ecuador. This was 2008 and 2009. And I worked at their busiest hospital, the Hospital Luis Vernaza, in their largest city, Guayaquil. And it was a fantastic hospital experience, wonderful people that do great care with very limited resources. And it's a place that had the highest consistent morbidity and mortality that I've ever worked in. So you've seen some pretty ugly places I've worked in. This place consistently had the highest morbidity and mortality. I learned a great deal there. And one more picture, or maybe this too. Oh yeah, this is cleverness, you know. I like making something out of nothing and making medicine happen. That's one of the things I like to tell my teams about. And so this poor patient in Guayaquil, after having been struck by a car, had been injured, has a head injury. You can see that there's a person ventilating using their hand to breathe for the person because there's no machines available. And they had a broken and deformed leg. And because there was no splinting materials, they kind of, you know, said, well, we can't straighten the leg. And I said, of course we can do something. And so I grabbed a cardboard box and unfolded the box and cut it with my scissors and turned it into a triangular splint and made the leg straight and taped it together. And the thing I'm really proud of is tríptese con cuidado, which is handle with care in Spanish. If you can put a splint on with cardboard, you're doing good. If you can arrange it so that the cardboard splint has handle with care on the outside, right side up, that's excellent. So, and then there's one more picture, I think. This is the first day of me working in Haiti. It's the first time where doctors arrived and we're starting to prepare patients for the first surgery. It's first hours into it. This is before tents, before medicines, before resources, before electricity, before water, before security. And it's a scramble. And here I am assessing the girl's wound, trying to decide where she might fit into the queue going into the operating room. And very good. So that's my experience I draw on to produce this list of lessons. They're neatly piled into senseless groups. So let's start it. You got control. You tell me when to go next. Personnel is one of my groups because the people you work with and the people you take on a disaster make a big difference. So one lesson is disaster work isn't for everybody. You know, everybody might have their heart in making a response to disaster, but maybe not everyone has to be in the disaster zone to do that. So getting into those places, you have to size up. Do I like that kind of environment, that kind of insecurity, that kind of unsureness, that kind of frustration, the kind of safety threats, comfort threats that you might have? Or are you better served in a planning, preparation role or support role somewhere away from that front line? Know your own personal limits and know your teammates' limits, and looking at your teammates and seeing, you're a little too tired, you should go home. Yeah. You look like you're okay today, but you should maybe go home. Or I can see you're getting really upset. Let's take it offline and see if we can help you get together. You know, so know your teammates' limits, know your limits if you can. And then there's a mix of the right staff, and as we're trying to plan the staff for these things, I imagine a pyramid, and unfortunately the only thing about the pyramid is at the top you imagine there's an important person, but at the top is the doctor. That's because that's who you need the fewest of. And then below the doctor you need a lot of nurses. And below the nurses you need a lot of support people. Think about an operating room with a surgeon, right? This is the one surgeon and the one patient. But the surgeon can't even pick up a scalpel without a nurse handing it to him, right? Scalpel, you know. So, okay, and then there's another nurse running around getting all the other equipment they might need. So that's two nurses. And they've operated on one patient. That patient goes outside, needs a nurse to take care of them after the surgery, and they're going to start doing another surgery. So that's three nurses. And we've only taken care of one patient. We're ready for the next one. We've got three nurses tied up. And then you got to clean that room that they operated on. And you got to put the debris away somewhere else. You got to move the patient. All the people it takes to do that one doctor's work means there's this pyramid, and you got to get organizationally, you have to structure your team right so you get the right number. You know, give me 5 nurses for every one doctor. I'm happy because we doctors, we need a lot of help. There's a can-do attitude that should come with people that go out and do disaster medicine. And you can imagine that attitude might be like, you can't stop us, right? You got to have that like, we're invincible and we can do it, we can do it, we can do it. There's a challenge we had early in the Haiti deployment where 800 or so, more or less, patients chaotically scattered in the field around the hospital, and we needed to administer tetanus vaccine because I have a great fear of tetanus. And so we finally received some tetanus, which has to be delivered cold. It has to be in a refrigerator and go to a refrigerator place and then be in an ice box. And so it's hard to do that. But we finally had tetanus. 800 patients, they all need to have tetanus. And one afternoon I said to one of my doctors, hey, vaccinate the whole hospital, okay? She had a little panic for just a second. She's like, but that's a really hard job to do. And then we quickly said, easy, there's 3 or 4 nursing students here. They don't know how to give shots yet. Get a magic marker. You go to each of the different sites. You teach one of the people at each of the sites how to give the vaccine to everyone on the site. You put a big T on their arm for tetanus. You give them enough to do that site, and you go to the next site. In about a half an hour, she came back and said, yeah, campus is vaccinated, 800 people done, all set. What's the next task? You know, that kind of, don't be afraid, you can do it. That can-do attitude. And then to get the right kind of personnel, we can't just go to one pool of people that like to volunteer or academics, or we need to engage everybody, and that's why I said we need to engage the private sector of emergency medicine at least. 90% of emergency doctors practice in private practice. They're not attached to universities like I am. And that means a big workforce is out there in private practice. I want to get them involved.
But, I'm sorry, Doctor.
Please.
How much are you engaging at the site, at the local level, where the emergency is taking place, and how much are you?
You'll see that exactly in the next slide, or two. That's a very important point that you're making, and I couldn't agree more. You'll see it. So give me another one. And I'm thinking that in those first days of a disaster, this is one of the things about disasters, and we saw this in New Orleans, we see it everywhere. In the first moments after a disaster, the doctors have to worry about themselves and their families, right? You know, and it's hard to go think about being a doctor for those first days. After the dust settles and my family's okay and they got a place to stay, and then the doctors and nurses and hospital workers can start thinking about coming back to work. In the very first moments, I probably need to have a lot of non-local people helping, even no matter where it is. The local people are busy taking care of their own. They can't go out and take care of the others for those first moments. Logistics, that means, you know, getting the stuff together. We have a saying in medical school, if you're foolish enough to go to medical school, it says 90% of the diagnosis is in the history. And I think that's probably true. Talking to the patient, they basically tell you what's wrong with them. So you don't really need to do a physical exam sometimes. I've changed this to be 90% of medicine is logistics. You know, most of medicine is logistics. Getting the equipment, the caregiver, and the patient in a place where you can take care of them is huge logistics. You take for granted that there's lights on and a tongue depressor in the doctor's office that you go to, but it takes a lot to have the lights on and the room clean and a tongue depressor in that drawer. A lot of stuff behind the scenes happens. I have this little story about 9/11 and Sawzall blades, and the story goes something like this. Me and my special response team that we had together got onto the rubble pile at September 11th, and there was the last live rescue happening. And the incident commander asked me and one of my medics to come stand with this patient's down in a hole. And the scene is amazing with the rubble pile is incredibly hot, and there's this snake of a line of people going up into the pile where the patient is, and it's hot. It's really, really hot. It's hot like pavement on a hot summer day, barefoot. You know, really hot. And so in order to stand on this pile, you have to be spraying the area with water, fire extinguishers. So those silver bottle fire extinguishers are being passed down this line, and at least 100 people long line. And along the way, if your feet were getting hot, you would spray some, and then you would pass the bottle, and then it would get empty, and you'd throw it, and there's a stream of empty bottle extinguishers going all the way up to the mouth of the hole, where you have to spray down there to keep the patient cool, because he's getting burned as he sits in the hot metal. The logistics of that, think about it. You know, you need a steady stream of water-filled fire extinguishers going down that line. Pretty amazing. And then the Sawzall story is this: we needed to cut some rebar, some piece of metal, to help get him out of the hole. And so the saw blade had gotten dull, and so someone at the head of the line near me said, "We need some Sawzall blades," and the call went down the line to the street. And then when it got to the street, it went out into the neighborhoods, and then it went out everywhere. And a Sawzall blade finally arrived, and then slowly this huge pile of Sawzall blades kept coming and coming. You know, this fantastic large mound of Sawzall blades, which I could pick up and take home. But it's the logistics that you have to meet demand and supply at the right time, and that fit. It's really kind of tricky. That's logistics. Anyone know the Big Pen Radar O'Reilly reference? I bet the answer is going to be no. I do. You do. Oh, but there was this show called MASH. Anyone heard of that? It was from a long time ago. They had color TV back then. But and you can look it up on YouTube because it's kind of cool. But Radar O'Reilly's is kind of he's a nerdy radar guy. He's a radio head. He's you know, he doesn't take care of patients. He's just a kind of a geeky guy. And a great character on the show. He's off alone, and the guy he's with suddenly can't breathe for whatever reason, and he needs to have a surgical airway performed. There's tools and kits and equipment that's very expensive and useful to do surgical airways. And Radar O'Reilly calls in base and says he's dying, and they say, take out your pen, and he pops his pen into his trachea and saves the guy, is the story, and so he can breathe. Does a cricothyrotomy with a pen, as the story goes, and that just goes to say that logistics is not always about having the right piece of equipment, but it's having enough to make it happen. And logistics sometimes lets you down. Not their fault. You got to deal with it. Tents and teams can fail sometimes. We've watched deployments where they're big tent operations, you know, mobile tents, military tent gear, big things, 10, 20 cartons worth of gear, and they're missing the spark plug for the generator that's going to power the pump, that's going to pump up the tent. And they sit there wishing that they had a spark plug that's the right size. So, like, or a tent pin, a little tiny piece of metal to hold your tent up, and you can't put the main frame of your tent together until that tent pins show up and they're shipped in a separate box. So it's funny, you can think you have all this gear together, you got your car, but you don't have your car keys, you got nothing. So we can be kind of hamstrung by those things, or our systems, you know, don't let those things get in our way. Tiny parts can make for big failures, and doing without is okay. You know, St. Lucia we think of as kind of a vacation resort place, and it sure is beautiful, but when I was there doing my year after residency, there was a month where there was no water and no electricity for 1 month. That's a long time to not see the lights go on at night and to not have the water come out of the tap. And during that month, there was also no pediatrician and no orthopedic surgeon. And so as an emergency doctor, I was going to every baby delivery and resuscitating the baby. Every broken bone, I was putting pins in and putting them into traction. I was taking them to the operating room and washing out their wounds and putting them into traction. I was doing what the orthopedists would do if they couldn't operate. And I was doing that, and I was working as an emergency doctor. I was doing a lot of work for a whole month. And so you can do a lot with a little. Let's give me another slide. Logistics is so important, it deserves another slide. Yeah, if I didn't make my point about logistics, this makes my point. You know, they really are important, 90% of medicine. Give me another slide. Inspiration. I think that there's a little bit to leadership and inspiring people to get to work together, and inspire your partners to work alongside of you. You know, there's a little bit to that, and there's some inspiration about doing disaster work. It can be heavy work, it can be sad work, it can be rewarding work. But my main lesson I like to tell people is you make medicine happen. So whatever that means, you make medicine happen. You can make medicine happen with a big pen if you're Radar O'Reilly, you know? You can make medicine happen with the tiniest of tools. So whatever you got together, you can make medicine happen with it. You'll be amazed at what you can do with so little. And I can or might steal anything if I need to. That's just the facts. So, you know, it happens. That logistically, sometimes you need to procure certain stuff. I'll pay you later. I'm taking your stuff right now, and I'm taking care of someone. I stole an anesthesiologist from the Red Cross group because their operating rooms weren't up and using, and I was getting tired of doing anesthesia. And so, you're an anesthesiologist and you're not working, you don't have an operating room yet. Come with me. I can't. Come with me. I'll buy you lunch, you know? And I had him working pretty soon, so I stole an anesthesiologist. Local incapacity is transient. They'll recover, stay out of their way. And this might be something that you were referring to about getting local people involved. You know, the incapacity that happens after a disaster to deliver health care or whatever services that might be needing delivery, that incapacity is going to go. It's going to, and if we get out of the way, the local people will start filling in that incapacity. A good example is this Banda Aceh tsunami response. Mm-hmm. About a month into that response, another national, non-US national surgical hospital was up and running finally. They'd finally gotten their spark plug. And they got their hospital finally. It's been a month now, and they got their hospital up and running. But all the surgeries related to the tsunami were basically done. It's been a month. So they were taking care of, like, hernias and, you know, gallbladder surgeries and, you know, little kind of elective surgeries. They wanted to operate. They were there with their tools and their doctors, and they were a little frustrated that they were so late at it. But they were doing elective surgeries. And I come to think of it later as probably a problem. Because if you imagine a month's gone by and the general surgeon in that community is now recovered from or trying to recover from the loss of his house or his family, whatever, it's time for him or her to get back to work. And he or she shows up at the hospital and says, okay, I'm ready to start charging $10 to fix hernias. That's how I make a living. I fix hernias for a living. And they see that there's someone doing it for free. And suddenly they can't go make their money anymore, and they can't restart their lives. And so we become in the way. And the right thing to do is get that person engaged in doing the work. I like to say this, the highest ranking doctor or nurse in a disaster is the local doctor or nurse. When I'm working with a local doctor, that person outranks me. I don't care how smart I might be or how dumb I might be on a given day, what degrees I have or he or she has, they outrank me. And so when I'm there working for them, we're collaborating, I'm working for them. If they can do the work, I'm going to step back and let them do the work. If I can show them a new way to do it in a teaching, non-threatening way, I'll show them a new way to do it. If they can show me a new way to do it, I'll gladly take the lesson. Give me another slide if you don't mind. Boy, there's more in inspiration. Capacity is multiplied by flexibility. Flexibility makes us so much more capable than if we're rigid. And a really good example of this is a fantastic OBGYN man that I worked with in Aceh also after the tsunami. Now this is a very Muslim part of the world, a very rigidly Muslim part of the world, and they haven't seen a lot of Westerners because they have kind of been a closed place to Westerners for a long time. So when this white man shows up and says, I'm an OBGYN doctor, you can imagine that he wasn't like, oh great, let me have all my women come and be seen by you. It just wasn't going to happen. And after about a week, he came to realize that he was not going to do obstetrics and gynecology. He's a doctor, but he's not going to do it there. And he had two choices. He either could, petition to one of the leaders of the team and say, hey, fly me out of here, I'm not going to work. But he didn't. He came to me and he said, hey Rob, look, I'm not an emergency doctor, but I can do something. Take me to the emergency department with you. I'll wash wounds, I'll sew wounds, I'll hold things, I'll carry things, I'll move patients, I'll give meds, I'll do whatever. And so his flexibility gave me another healthcare provider in a time where there still weren't any local healthcare providers to provide help. So flexibility increased our capacity in that moment. And the humbleness of a guy who's generally a surgeon, probably a big wig, gets a lot of money, drives a fancy car, to say, look, I really don't know what I'm doing, but I'll do anything. That was really great. Gives me chills. These are not droids you're looking for. Does anyone know that reference?
Star Wars.
Come on, God, Star Wars. That's like in the theaters now, for Pete's sakes. These are not the droids you're looking for. I think you can actually tell people things like, you can go vaccinate the whole campus. You're right, I can. I can. I said to one of the young doctors, I said, go set me up a tetanus ward. What do you mean? Tetanus. Remember, that's a disease that's going to be coming pretty soon. People basically are bedridden. They need a quiet place. They need some nursing supervision. They might need some sedative medicine that needs to be safe, cool, quiet, away from stimulation. Because when you clap, people with tetanus start spasming. You can do it. Okay. And off he went. He set up a little tetanus ward, a little place with some quiet beds away from every other noise and stimulation where a nurse could tend to patients. So as our tetanus cases came in, they could be dealt with there. But telling an emergency medicine resident, capable kid, to go set up a ward, go build a battleship. Go ahead, build a battleship. Oh, I can't do that. Of course you can. Of course you can. These aren't the droids you're looking for. For a community to heal after a disaster, they need to get on with their lives. I mentioned this kind of once already, but it's really, really true. They need to get back to work, get out of their way. If you're doing their job, let them do it. They need to get back to school. They need to grow their economy again. They need to grow their agriculture again. They need to rebuild those activities that they did before the disaster. That's where they're going to pick up. So get out of their way and let it happen. Don't get in the way of local workers working. Why should I go someplace and clean a ditch when there's guys that are looking for work that want to clean a ditch and get paid a little bit of money to do that? I'm happy to clean a ditch if I'm the only guy to do it. But if there's some local guys that want to do it and that's their income, I got to get out of their way. Security. This is about deployment security. Again, early on, these situations can be pretty unsettled. And so you are a prisoner to the security rules. You're basically, I like to use the term, self-propelling luggage. Security tells you where to go, and you bring yourself there. You don't make any decisions about where you're going. Security does. And that's for your own safety. And so if you're thinking about, hey, maybe I'll go for a stroll this afternoon. It's pretty down by the beach, maybe. No, if security says you stay on the compound, that's where you stay. You are self-propelled luggage. Sometimes the less you know is better. Like security, they're doing their reconnaissance, they're figuring out what's going on. I really don't want to know that there's some armed group looking for blah, blah, blah. I don't want to know that stuff. They'll take care of me. The less I know, the better. Some people want to know it all. I don't. I trust it. It's their job. Wear your seatbelt. More people get hurt in disasters from car accidents than all other causes combined. That's easy. Put your seatbelt on, dummy. You're not going to get kidnapped. You're not going to get shot. You're not going to have an earthquake, have a building fall on top of you. You're going to have a stupid car accident because someone was going too fast, and you're going to have either no injuries from wearing your seatbelt, or you're going to get injured. Bless you. So wear your seatbelts. Avoid appearing rich. I think dressing down, this is the moment. Less bling is good. And avoid conflicts. That may be conflicts among your peers, conflicts among other NGO groups, non-government organizations that you're working with. It might be conflicts with the local staff, or conflicts with patients or their families. So you should be conflict avoidant. You know, I'm not saying be completely passive, but be conflict avoidant. Always try to de-escalate. And life is a stage, stay in your role is another one of my ideas as far as this goes for security. That is, I'm a doctor. I play a doctor at work. And I don't play something else at work. I don't pretend I'm security. I don't pretend I'm logistics. I don't pretend I'm not nutrition. I don't deliver food to people. That's not my job. I do medicine. And so I stay in my role all the time. I'm in my role.
Except when you need to be flexible, right?
Except when I need to be flexible. Never break a rule except when you have to.
Right.
That's true. I am very flexible. But truly, if you stay in your role, you won't get in much trouble, you know. And there was this coordination with some nutrition services that had to happen at Haiti. And I was the kind of broker between the hospital and the nutrition agency that ended up delivering food to us. But I got out of the way after I made that connection happen. It's not my job. I'll have another slide if there's any left. Nomenclature. This is just because we all, especially if you work in the government, even at school, you know, you guys are getting a degree, and what are the initials you use for it? MBS, PPCA, you know, everyone's got initials for everything. And initials can be confusing. Anyone know what IOM stands for? Give it to me.
The International Organization for Migration.
Migration, right. And unless you're a doctor, then it means the Institute of Medicine, which is the largest government organization that looks at scientific data and helps us understand science. And so when someone says IOM, I'm like, oh yeah, IOM, sure, Institute of Medicine. I've got some of their pamphlets, I read their stuff all the time. Every doctor thinks that. But then, you're right, migration is a whole different topic. If you Google it, migration beats it by one. But then we get them outnumbered because there's lots of IOM articles. Nomenclature is funny. So nomenclature came up. In Haiti, I got to see a cluster, and it didn't mean what I thought it meant.
What did you think it meant? Is the question.
It kind of did mean what I thought it meant in the end, but initially. But then there are these like logs. I'm like, we need to get more logs in here, and it's 95 degrees. What are these logs? Who's making a fire? But logs is short for logistics, and comms is not calm down. We need more calm. Well, calm. I'm not loud. Comms is good. So NGO means non-government organization. I put that in as kind of a joke, tongue-in-cheek, like you should at least know what that is. But etc. We can get lost in these little letter things. Make sure the audience you're talking to speaks your language, thinks IOM means, Institute of Medicine, because that's what it means. I don't care what you say. And make sure we're not using letters, and that goes to you. Make sure we're not using just letters randomly and having us assume everyone speaks your language. Give me another slide. Manners. A big heading. Host countries are hosts. They've invited us in. We are. Treat them like they're hosts. If you guys came to my house and you're walking around with dirty feet, I'd be ticked off. I'm your host. So behave like a host. Please and thank you can work wonders. It's amazing what you can get done with a please and a thank you. Don't be easily offended is good advice probably for always, but especially in these pressure cooker situations. If someone does something or speaks too brashly or does something you think might be offensive, let it wash over you, go away. Because if you're easily offended and you carry that with you, you won't be productive. Just don't be offended. Let it go, and then don't easily offend if you can help it also. We're ambassadors when we're out there in disaster response internationally. If you go someplace really rural, really off the beaten path for just a little while and come away, you might be the only Caucasian, only American, like I'm the only white guy some people saw in some places, And what they think of me is what they think of the International Medical Corps and what they think of the United States, because I represent them. And so I'm an ambassador. And so you behave like an ambassador. I tell my kids that when we're traveling. We lived in Ecuador for a year. We lived in St. Lucia with my kids. Behave yourself, you're ambassadors. Ooh. Well, suddenly they stood up straighter and said please and thank you. It doesn't work so well at home, but it works pretty good when you're in Ecuador. And then we're guests goes with the host thing. They fit together. But we're guests. We're going to pass through. We're there only for a little while. And then we're going to leave behind everybody who's staying there. And we have to get out of their way, but at the same time recognize that we're just transient. And if they want to do something some way, and that's the way they're going to do it for the next 20 years, we should do it their way. we're guests. Give me another slide. Let's see what we got. Oh, training may help. I say this with some cynicism. I'm a teacher, so you might think I think training is everything. But the training might help with us doing a better job in disaster responses. We have, the only constant is change, and people need to learn that the environment is very dynamic, and that the environment will change every day, and the mission will change every time. And so training for that difference and trying to teach people how to be dynamic might be helpful. Team mental health or post-traumatic stress syndrome, or PTSD disorder, is an important piece of this disaster work. We get pretty darn tired. We work pretty hard. We see some pretty awful things, and we got to do it again tomorrow. And how long it takes for that to turn you from sad and fatigued to diseased and unhealthy is an important question. And I think there's some ways of preventing that. There's a little bit of science to say that if we can expose people to tiny doses of stress, maybe like I have this 5-point Fuller scale where a 1 or 2 might be St. Lucia when there's electricity and water, and then day 1 and 2 in Haiti might be a 5 on the severity index. Maybe you might expose people to a 1 or 2 for a short period of time, have them go on a little mission, kind of disaster light mission, and see how they recover and see how they feel about it. And if they feel good and they have a pretty good mental recovery right after that, then they might be ready for a 3 or 4 exposure. And the fact is your brain starts getting wired to see that you can go into a place, feel uncomfortable, unsafe, deal with terrible things, and then come back home and get to be normal again. And that training of I can survive this gets to be, it's like tightrope walking. The first time you go across, it's very scary, but when you get really good at it, you do it all the time. You just do it all the time. So there's a little bit of training for that might help. Austere medicine is a course I've given a few times. It's a very intense 3-day course where you come to a conference room like this and you shake hands. Hi, we're all going to go to a disaster. A van pulls up, and then you go and you grab your gear and you get dropped off in a dark place and you wait around, and then you carry it through refugees and this simulated patients and this simulated armed conflict and you spend 3 days in a field living, building a hospital, taking care of a bunch of patients. It's very, very stressful. But it teaches you how to live a little bit off the land, how to be scrappy. It teaches you how to think about safety, about yourself, your gear, your personnel. So it's a nice course. Maybe a little training might help with that. Being physically fit, I think, is incredibly important. People that aren't well shouldn't go to that front edge of the disaster. They can be back a little bit further away from that front edge. But being very healthy is very important, mentally and physically. I stay physically fit so that I can go to disasters with the International Medical Corps. It's one of the reasons I like to be very fit. I can still carry my bags and march for hours. And plus, I like to kiteboard, and you need to be very physically fit for that. You know, maybe that's really the important reason. I carry with me on my back, as far as training goes, I always carry with me when I deploy to a disaster. It's not an inset situation where it's been going on for a while. We know what the housing and food's going to be like. I carry on my back 3 days worth of stuff. I can live for 3 days. You can put me in the desert, you can put me in the jungle, you can put me in a field. I can take care of myself, thank you very much. I got enough. Food, water, shelter, sleeping. It's nice when I don't have to crack into that stuff. I have Milky Ways left over for later on in the trip. But if I have to, I can space out those Milky Ways over 3 days. Don't bring any of your baggage with you. If you've got some baggage, you shouldn't be out there at that very front edge in that early disaster deployment. That means drug addiction, alcohol, mental health disease, medical diseases that require medicines and like, and nothing against anybody with those problems. They're problems, and I appreciate they need to be worked on for them. But if you bring those to the field, they make you a liability, and you're no longer an asset, you're now a problem. Something as easy as diabetes, which is controlled with insulin, which is kept in a refrigerator. If you go someplace where there's no refrigerator, you got a medicine you need to get an injection of twice a day to live, suddenly we got someone who's diabetic and sick on our team that we got to figure out how to take care of and get them away. So don't bring your baggage with you. And then you heard about my 1 to 5 disaster severity index. Give me another slide. This is the 19th slide. You can't have more than 20 slides, so I had to fill it. This is and then one more slide is the end, which is the beach where I lived on in Ecuador. I lived on the beach for a while there. So anyway, that's a little talk about the lessons that I've learned from these deployments with the International Medical Corps and other international experiences. and my view of what some of these things might be.